Hindu priest would be there, as well as a mosque person would be there. And I would write in the notes for the clergy to visit the patient, especially in patients who were metastatic, and we could say, okay, the clergy to visit him or the local imam to visit. And there was an on-call rota for the imam. So you would ring the switchboard. I worked in Bradford, ma'am, so that's the reason. So you would ring the switchboard and say, who is the imam on call locally? And they would come around and spend half an hour with the patient. And we as a society, we are supposed to be much more religious than them. But you never have access to that in India. आपको अगर होता, would you have used that? अगर आप ट्रीटमेंट ले रहे हैं, यस, अगर कोई लोकल इमाम जिस पे आप थोड़ा विश्वास करते हैं, आके अरे बच्ची क्यों हो रहा है, कुछ बात कर, उनको बुलाते हैं?
नहीं सर, मैं ऐसा किसी को बुलाना या वैसा नहीं, मैं खुद सेल्फ प्रे करती हूँ, किसी का मतलब मैं किसी के ऊपर डिपेंड नहीं हूँ ऐसा कि कोई मुझे आए, और ऐसा जो आप बोलना चाहते हैं मैं प्रॉपर समझ पा रही हूँ या नहीं, ऐसा कि झाड़ फूक या कुछ इस तरह का, ऐसा कुछ नहीं। मेरी खुद कनेक्टिविटी गॉड से कि हाँ मुझे उससे मांगना है, और वो एक ज़रिया है मुझे स्ट्रेंथ देने का। और इसमें जो है कैंसर में डॉक्टर का रोल, मेडिसिन का रोल होते हुए भी, लेकिन एक स्पिरिचुअलिटी को हम निगलेक्ट नहीं कर सकते, उसको इग्नोर नहीं कर सकते सर, क्योंकि अगर डॉक्टर को हम गॉड मानते हैं तो गॉड विल डोंट कम डायरेक्टली टू ट्रीट अस, वो उसी
हम क्या जानने की कोशिश कर रहे हैं आप लोगों से कि हम सबके अपने अपने कहीं कुछ फेथ होते हैं
जी।
ये फेथ हो सकता है कि हमारे रिलीजन से संबंधित हो, ये हो सकता है कि हमारा कोई स्पिरिचुअल गुरु हो जिसको हम मानते हैं, हो सकता है कि हमारा कोई टीचर है जिसके साथ हम बहुत कनेक्टेड हैं, हो सकता है हमारा कोई रिलेटिव है, पर जिनके साथ हमारा वो इमोशनल कनेक्ट है एंड इट मे और मे नॉट बी रिलीजियस, उनकी प्रेजेंस से आपको लगता है कि आपके ट्रीटमेंट के दौरान आपको एक सपोर्ट ज़्यादा रहता है। अगर ये सपोर्ट जो है रिलीजन से रिलेटेड रहता या फेथ से रहता, तो क्या आप पे वो फर्क पड़ता? क्योंकि ये एक ऐसा चीज़ है जो कि यूके में एक सिस्टम का पार्ट है एक्चुअली।
I'm going to ask Rupali that question. Let's say that as a part of your support structure, yes, and I'm not talking of religious support structure, I'm talking of spiritual one, wherein depending on whatever the faith is, that's the reason the holistic assessment was important. So if I was going to call for the clergy to come in, I knew that they believed in that part of it. Or if they say that I'm a Buddhist, then you would get in contact with somebody. So do you think that would be helpful, or we are talking of something that is not required?
So probably what Fatima is trying to say is...
No, I just wanted your opinion.
Okay.
Yeah.
It's very difficult to, in India, a place like India, which is multi-diverse cultures, we cannot really put compartments and say, okay, this is the religion you follow.
I didn't say religion. I said spiritual.
Spiritual, okay. It could be either way, spirituality. So spirituality for me could be even having a blank canvas, paint, and I can go towards spirituality. For
no, sorry, I'm not trying to categorize. I'm saying we are not even offering any. Yes? So at least a thought process on that, is that necessary, or that's totally different to allopathic medicine which we are trying to deliver here, and that we should not visit that part.
If you allow me to complete just 1 minute, basically, as we might say, spiritualism, religion, etc., it's faith in oneself. And there is inner faith, and you just asked at the beginning of the session, what is the role of the family, the role of everybody near and who's near you. So there is a lot of give and take of information, there is a lot of give and take of see, what happens in India especially, people cannot, there is always a faith, there is always a fear of going. But having faith in yourself and having the faith that tomorrow I have to live because I have a family to take care of, it gives you that inner strength which is enormous. So then all the other things come by.
Thank you very much. I'm going to ask Murthy, try to be short and just say that, do you think these kind of services would be of any use?
I would definitely take it, in simple.
Raj sir, the senior most among the lot.
Absolutely no doubt. I'm not talking from my experience, but seeing all the patients who come and talk to me while I'm waiting for 3 hours with my wife. Okay. No question about it.
Okay. And Murthy, I'm going to come back to you again. Because you being a young patient, there were more things that you were frightened of, and there were more things you were insecure of. You still hadn't been formed as a full character taking up. Did you ever think that it would have been better to have a psychological support or counselor or a psychiatrist, anything of those things, and were you ever offered?
Absolutely yes. It would make a lot of difference. It all depends on how physically or mentally strength I am, but it is not the case with everybody. So if it is a part of the entire journey, patient's journey, if some kind of psychological support can be given to the patients during the treatment, it makes hell a lot of difference in the patient's mindset.
Okay.
So it is very much, if it is possible, yes.
Yeah, this was when we were in Christie Hospital. We used to do partial penectomy, and at 6 weeks down the line, we used to do groin node dissection. 2 patients committed suicide within that 6 weeks time period. Since then, no penile cancer patient would have, always they were done psychological assessment at the time of the clinical consultation, and every follow-up appointment, there was a psycho-oncologist who was available there. And unless these events happen, we don't understand. Doing a mastectomy on a woman, we are doing something that God didn't want us to do, and we just do it as an anatomical operation when the psychological impact is so much more. Vedant.
I always wanted to ask this, and this is perfectly the right question I wanted to ask. Now, you've just been diagnosed with certain cancer, curable, likely, you're planning a certain treatment. At that time, if I as an oncologist, should I say you should go and meet a psychologist? And what? I don't do that. I probably should, but I don't. I don't see the context, how to put it in context to a patient. Indian.
Yeah.
I would like to say something. It is not that what I said is that I immediately I would not want a psychologist to sit in front of me and do something. I'm saying when you are sitting with the patient, I'm sure that as a human being we might be able to assess his mental agony or the strength what he is going through. If you identify in the process, then probably during the treatment of the patient's journey, at certain point of time, if it can be given, if it is possible, then definitely that would make a lot of difference. That's what I mean to say.
We moved from being selective, because what was happening was patients felt almost being treated differently the moment we said, yeah, go and see. So that's the reason, as a part of all testicular, young and adolescent cancer, there was a psycho-oncologist. Every penile cancer, there was a psycho-oncologist. So it was done. Every patient would have it rather than not having it. Raj, sir.
Can I just answer the question? Not everybody needs psychological help. In the US, I found that there's a nurse assistant who spends 15, 20 minutes or half an hour going through a list of 60 or 80 questions, and that gets analyzed. So each patient gets categorized as to what their needs might be beyond medical treatment. So the doctor knows that this person probably needs a lot of mental support or whatever it is. So those people can be provided, but not everybody needs it. But that is missing in India. Doctors have no clue about what the patient situation
I
is.
would like to add something. What happens is the body language itself talks a lot on volumes when the patient walks in. Simple things like, how was your day? What has it been? Have you attended any celebrations in your family? They indicate a lot of things what the patient or the caretakers are undergoing, and that is very good.
Okay. Ravi, yeah.
One small question, as I'm sitting across the table and talking to patients, when they come with a diagnosis of cancer, the attendants would be knowing it, and they would categorically say, doctor, please don't tell the patient, please don't tell the patient it's a cancer, because if you tell them, you're going to go down and they're not going to accept treatment. And for cancers which we deal, genitourinary, they almost always will affect one of the biological things, so we need to tell them. So what is your reactions, or should we as a clinician tell the patient and explain them versus not telling and discussing it later? Yeah, I'm a professor of virology at PJ Chandigarh, so we have an equally long rush of patients.
Yeah, in my opinion, yes, you should tell them, you should explain them the entire the process of what is going through and what might be the consequences in front of, probably along with their family. Yes, you should tell them, because if patient does not know what is going through, then that fear is much higher than the, at least if he knows it, he might accept it. Most of the patients might accept it. They might stand and take it. So
In fact, I would add, in such cases, the patients are very proactive than the caretakers, and the caretaker needs a lot of handholding than the patient. So at such times, it's better to be open and counsel the caretaker better, in a better way.
सर मेरे हिसाब से फर्स्ट अटैम्प्ट में नहीं बताना चाहिए। अभी जैसे गीताली मैम ने बोला कि बॉडी लैंग्वेज से डॉक्टर को समझ में आ जाता है कि किस में कितना विल पावर है, तो डॉक्टर को थोड़ा सा पोलाइट होके उसको पेशेंस रखना चाहिए और उसको पेशेंट को मोटिवेट करना चाहिए कि तुम्हें पॉजिटिव रहना है, मैं भी पॉजिटिव रहूँगा एंड वी सी द रिस्पॉन्स ऑफ आवर ट्रीटमेंट। जब तक वो उसको एक होप नहीं जगाएंगे, जब जो होना है वो डॉक्टर को फैक्ट वो मालूम है कि हाँ कितना टाइम है क्या है, डॉक्टर नोज एवरीथिंग, बट पेशेंट की उस टाइम जो मेंटल जो हाँ एक्सेप्टेंस रहता है तो वो उस टाइम नेगेटिव नहीं सुनना चाहता, वो इसी होप से आता है कि डॉक्टर कुछ तो पॉजिटिव बोले कि हाँ मैं ठीक हो सकता हूँ, क्योंकि उसका कहीं ना कहीं बहुत सारा कनेक्शन रहता है, किसी से अटैचमेंट रहता है, तो वो एट अ टाइम वो ये नहीं सुनना चाहता कि हाँ नहीं अभी तुम्हारे पास इतना टाइम बचा है या तुम्हारे पास इतना % है, चांसेस है, तो डॉक्टर को थोड़ा पॉजिटिवनेस उसमें भरना चाहिए।
Okay. I'm just going to, just so that we can, I will allow you to. So I just wanted to, this one was started by a doctor who was diagnosed with a terminal cancer. This was around 2013, around that time. And it made me think quite deeply, and I continue to do what she told us. So one, she was a Kate Granger, she was a doctor, she was a, I think, elderly care physician. So what she said was quite true, in that I'm there in my room, a doctor walks in, doesn't introduce him, he'll just says that, yeah, you're fine, I'll come around, we'll start the chemotherapy tomorrow, and then walks off. You spend 2 minutes with me, I've got the next 23 hours, 58 minutes to ruminate what you told me, dissect what you have told me, try to understand the meaning of what you told me. And I think that's very unfair. We are the caregivers and they are in a very vulnerable situation. So this was a very simple campaign, hello, my name is, which is what everybody, so the moment you go in, hello, my name is so-and-so, this is my, I'm a consultant here, I'm going to look at you and we'll see what we can do for today. Second thing she told me is, just sit down. I might do the same talking, but I always make a plan to sit down. Thankfully, we don't have that many patients in cancer, i.e., when as inpatients. So I just sit down to say, okay, how was your day? What was it? That just gives them an understanding that I have got the time to think about you, listen to you, and provide the care. I do that every day, and unless it came from a cancer patient, probably you wouldn't have heard that. And when I had to go through my dad, what Ravi was saying, that when I knew that he had cancer, for 2 days I knew before I told him, it was absolutely difficult because I'm trying doubly hard not to tell him the truth, and I'm sure he's intelligent enough. I'm bringing him to a cancer hospital. Doesn't he know that? He's trying even harder not to let me know that he knows. And the moment we just sat down and said, okay, this is the problem, he just said, fine, we'll deal with it. Yes? And half of the treatment was done. I just felt relieved. He knew what the information was. So I always say that we have to have a valid discussion with all the patients, explaining the overall management plan. Sorry.
Sanjay, sorry. It's okay.
Yeah.
It's okay. Go ahead.
Yes.
So revealing a bad message to patient is an art. Many residents are there, youngsters are here. In which way you should not reveal the bad message that over the telephone, on the corridors, or once we are examining the patient and patient is without clothes, all the things. Those situations you should not tell to them. So along with that, while telling also the technique is sandwich method. Sandwich method.
Yeah.
Are you getting my point?
The way I tend to say is you give good news and you break bad news. No, break bad news.
Yes.
So let's say if I won a lottery, I just said I won a lottery. Whereas if I lost something, you say, Dad, you gave me a pen yesterday, which was nice pen, I lost it. So in the same way, we just have to break it into bits.
Yeah, this patient counseling sandwich method is more applicable. Thank you very
Thank
much.
you. Malik.
Sanjay, I think the time is looking at Indian perspective, I have got well-resourced people in front of us. I'm lying and in the possible alternatives, one number.
Yeah, you just speak
So you
now.
can use this one.
In all our guidelines, it's said, this is suppose Mr. Nair is going to have a localized cancer prostate, you have a radical prostatectomy, you have a radical radiotherapy, you have an active surveillance. You look about and you decide what you want to have. All the options are being laid out. But in general, ultimately in Indian scenario or perspective, the thing what happens is, doc, you tell me what is good. Because of the perception that their decision making is very, very poor. Because they're quite less confident in making that decision about. Given the same choice for you at that point of time, whether it was you who decided for that treatment or it was the treating physician who decided for that treatment.
Raj, sir.
Obviously, my doctor Amit
That's
sir
it.
decided the treatment,
That's
so which
exactly-
I've
that's
completely
exactly,
believed
still we
in.
revolve around in
And
the
there
same
is a
thing.
lot of personal, as I said, connect. So it is just
Raj,
La-
sir.
Last,
regarding-
your time is up, sir. Last comment.
The same question?
Yes.
Okay. I couldn't hear the question fully, but the point is that I decided when I want to have a treatment and what kind of treatment, because I got excellent guidance on what are the issues in a very positive manner and a complete manner. If he had, let's say, bullshitted to me that in the first day, I would have lost trust in him. And even if he told me anything later, I would have said, look, I don't know how much to trust. But he laid it out very neatly in a very positive way, but complete way. So I could take my decisions.
Okay. Just one comment, sir.
Yeah, I think what I perceive at the end of the day is sitting on the other side. I think we all as a doctors, as oncologists, we need to give more time. We need to be more patient. And I think what I follow in our clinic with the heaps of experience now, let us walk this journey together. And that is the expectation from the patient towards the doctor. We may be busy, we may be technologically we may be advanced, but if you rightly said, if you don't sit down and take them through the journey, that is what the people are coming for. And I think we have to introspect ourselves and do that. Then we'll become a specialist rather than become